sit and listen until you start. Again, because I talk with this patient, I know that after a while he's going to develop the signs of triggers or urges. And these are basically physiological. He starts being a little bit anxious, nervous, and then the butterflies in the stomach start flying, whatever they describe, and they know because they've been through this. So the plan is for you to listen and remember what was the thing that
relevan, berkaitan satu sama lain, teruskan saja. Tapi kalau tidak relevan, kita stop. Mau bisa rangkaian yang terjadi sebelumnya itu selama kurang lebih 3 jam sebelumnya atau 8 jam sebelumnya, silakan saja. Selama itu masih berkaitan, kita bisa terus.
Okay, so this is the sequence. Start with the event and go step by step backward in time and going up. After you've done this, you obviously give him a lot of positive reinforcement. This is great, thanks for doing this, etc., etc. Now, let's see what happened after that. And you go down forward in time, starting with the event. After you use the drugs, how did you feel? What did they make you feel? Oh, I didn't feel anything because I'm on methadone, so it was a waste of money, something like that. And so you write it down, this event. It becomes a storyline, then you use it. So you tell, look, this is very useful. We just created a story. Let's review it. Let's see what happened yesterday. And then you start the review from the beginning, from the first event in the chain. So I work, and I was at work. Let's say the patient was in the office, and then the boss came and into argument that his supervisor told him, "You're not doing great. You're about to be fired," or something that upset him, and he went home angry.
Ya, jadi gambaran yang lebih lengkap sekarang kita bisa mendapatkan suatu cerita kan dari dia. Nah, kita review cerita itu. Kita mulai dari yang pertama sekali. Umpamanya contoh dia nulis bahwa yang paling atas yang dia tulis adalah dia pergi ke kantor, di kantor dia berdebat sama bosnya dan merasa marah.
And then, so he went home and he was watching TV and smoking cigarettes, but he was sitting and doing nothing. And he had other plans, but because he was angry, he decided to just go home and kind of cool off.
Nah, berikutnya namanya contohnya adalah karena dia begitu marahnya, tadinya dia berencana untuk pergi ke tempat lain, dia batalkan, dia hanya langsung pulang ke rumah dan tidak melakukan apa-apa selain merokok.
And then this is when his friend called, and he didn't pick up the phone initially because he knew there's going to be trouble or something like this. But then he kept calling, so next time or third time he picked up the phone. You get the picture. So you guys this time you're going from the beginning to the end. You're reviewing with the patient the sequence of events. Events, not just events, emotions, and thinking this time. Right?
Ya,
this is the cognitive behavioral part.
Ya, jadi apa yang selanjutnya terjadi, Bapak Ibu sudah mulai dapat gambaran barangkali pada saat dia duduk bengong nggak karuan tadi lagi merokok, tiba-tiba telepon berdiri dan dia lihat bahwa itu dari temannya yang memang sering kali menimbulkan masalah. Awalnya dia nggak angkat, tapi temannya terus-menerus telepon sehingga akhirnya dia diangkat dan sebagainya. Nah, di sini Bapak Ibu bisa tanya lagi lebih jauh apa yang terjadi. Selain apa yang terjadi adalah juga bagaimana perasaannya, apa yang kamu pikirkan. Jadi itu ada 3 hal yang harus ditanyakan juga.
And this becomes your storyline. You use this now as a starting point. So let's see what can we do to prevent things like this from happening in the future. Let's see what do we see here. We see weak refusal skills. We see this and that. We see that you have a problem with that you felt guilty by wasting the money, which can lead to relapse and etc. Weakening your desire to make progress because you may think that because of this, and then you get the picture. And sorry for going so fast, but we're actually running out of time. But you use this as a starting point. First of all, for you, it's useful for you to understand what strengths and weaknesses the patient have, and what you need to do to prevent things from happening for you. But the same goes for the patient. He also learns very explicitly what are his strengths and weaknesses, and what to do in future situations like that.
Ya, dengan cerita yang tadi kita sudah dapatkan, ya kita bisa ambil contoh, makanya kita berhenti pada saat poin di mana dia akhirnya tadinya nggak mau angkat telepon, dia angkat. kita bilang bahwa apa yang bisa kita lakukan di sini untuk bisa mencegah hal ini terulang kembali. Salah satunya dengan melatihkan keterampilan menolak ya. Nah, kita bisa mendapatkan suatu gambaran lebih jelas sekarang apa sih kekuatan dan kelemahan dari pasien kita ini. Dan bukan hanya kita yang mendapatkan gambaran itu, dia juga bisa mendapatkan gambaran apa menjadi kekuatan dan kelemahannya.
Okay, this is important is that you do not keep this page. You do not make a copy. This page is not for you. The page that you just created, it's not for you. You give it to the patient. You give it to them and say, this is yours. You take it as a reminder, use it in the future or whatever. Most often, that happens to me, that they want to destroy it. And they do, you let them do it. But this is their possession. Right? If you tell them that you're going to keep a copy, you're not going to get details. You want details.
Bapak Ibu, lembaran cerita ini tadi adalah bukan milik kita, tidak dimasukkan ke catatan medik, serahkan pada dia, karena ini menjadi pegangan buat dia, pegangan dia kalau menghadapi hal yang sama nanti di rumah atau di tempat di luar dari klinik. Nah, kalau dia sebagian dari mereka mungkin akan menghancurkan itu, dibuang dan sebagainya, biarkan saja, itu kan barang dia. Tapi ini sebagai reminder, sebagai pengingat bagi dia, apa yang harus dia lakukan kalau dia menghadapi situasi yang sama.
Relapse prevention is an area where identifying comorbid problems that you're not going to address in your therapy, your drug-focused therapy, but that if unaddressed would increase the chances for relapse, like high levels of psychiatric symptoms or medical problems. So this is an area where it's important to make those referrals that Marek was talking about if the patient has, marital, legal, whatever.
Or you may discover in this that the patient who was sitting home was feeling pain because he has a chronic pain ongoing that interferes with his function. This is where clearly one of the examples that Joe said, you don't deal with the pain. You say one of the relapse prevention will be, look, this pain under unresolved medical condition is something that you need to do with a pain expert somewhere else, not the counselor.
Ya, ini sebagai suatu pengingat buat kita semua bahwa kalau kita sudah masuk kepada masalah pencegahan kambuh atau relapse prevention yang seperti ini, itu biasanya akan keluar beberapa hal, termasuk diantaranya adalah komorbid. Ya, kondisi-kondisi komorbid daripada pasien kita. Nah, inilah waktunya untuk melakukan rujukan. Ingat Bapak Ibu, kita adalah konseling nafsa, bukan konseling yang lain-lain. Jadi kalau umpamanya contoh tadi pasien tadi datang ke rumah, dia merasakan ada chronic pain ya, dan sebagainya. Nah, kemudian itu ditulis, kita bisa bilang bahwa rasanya kamu perlu untuk pergi konsultasi untuk masalah kronik.
So you asked me before, sorry, I don't remember her name, the lady in the blue.
Ya, Budia.
You asked me before whether you should use the technique of positives and negatives, right? So this is another good relapse prevention. That again, you take a piece of paper and write down in one column. So I understand you used drugs yesterday. What good? How good it was? And you list positive things, and then what bad? So good was, I was feeling good. I was hanging out with my friends. I had something to do, whatever you list. The bad things, it was waste of money. I'm now sorry that I did it, and etc. In two columns, right? You know this technique, so it's a classic CBT technique.
Tadi pagi Ibu dia tanya sama Marek gimana cara apakah bisa kita gunakan itu kolom yang positif negatif, manfaat dan tidak ada manfaat dan kerugiannya dia pakai. Nah, itu bisa kita gunakan di dalam teknik prevensi relapse, karena itu merupakan suatu pendekatan klasik dari CBT. Jadi kita bisa tanya secara langsung, secara terus terang saja apa manfaatnya dengan dia pakai kemarin.
So this is another example that this counseling is not just talking, writing down, using pieces of paper, using charts, pictures, things, etc. All absolutely appropriate. The more multimedia you will be, the more effective you will be.
Ya, jadi ini bukan sekedar terapi bicara, ingat lagi sekali lagi, BDRC bukan sekedar terapi bicara. Lakukan itu, tuliskan itu, gunakan berbagai macam media. Semakin banyak media digunakan, semakin baik.
So, when should we do this activity? I mean, on which session? We don't do this in every session, right? Or
You do this after patient achieve some abstinence. You don't do this with an ongoing, this is a truly relapse prevention. So a patient is not using drugs but still experiencing urges. He's thinking about using drugs, or has been clean for 2 weeks and then used once, relapse. So these are the starting points are some sort of a relapse trigger impeding relapse. They are listed at the top actually. This has to be a behavior, or thinking, all right, or emotion that they associate with urges to use drugs.
Ibu Vivi nanya tadi, apakah kita menggunakan formulir ini, bukan ya, format seperti ini tuh pada setiap waktu atau kapan? Sekali lagi Marek menegaskan ini adalah bagian dari pencegahan kambuh yang biasanya baru dilakukan setelah orang itu stabil, datang teratur, tidak lagi punya risiko, tidak lagi menggunakan nafsa dan punya aktivitas waktu luang.
It has to be an actual event or emotion or a thought. It cannot be hypothetical. You can imagine doing this what if, but this is not going to be effective. I don't want to, let's come up with potential scenario that may happen in the future. No, this does not apply to the future. This applies only to the past. Something has happened most effectively yesterday, 2 days ago, and it has to be real, very detailed.
Ya, jadi pencegahan kambuh ini tidak bisa digunakan dengan cara mengarang cerita. Umpamanya, kalau kamu relapse, umpamanya kamu nggak bisa. Harusnya berdasarkan dari kejadian nyata. Dan yang paling bagus, yang bisa efektif adalah kalau kejadian itu tidak terlalu lama jalannya. Jadi mamanya 2 hari yang lalu, 3 hari yang lalu, kemarin dan sebagainya. Nggak bisa umpamanya, nggak bisa dikarang dengan cerita yang hipotetis ya, yang dikarang-karang itu nggak bisa.
Other techniques, like for example, role playing. Let's play a hypothetical situation that may happen to you next week, that you run into your friend who's offering you a ride from home to the clinic. What would you do? Yes, so not for this, but in another relapse prevention technique is a very good technique is role playing, preparing for future situations by developing scripts, by developing stories, what you will do, by developing plans. And these plans also can be written on a piece of paper, and they can carry it as a reminder to themselves, etc. So this particular piece of paper in this exercise is based on the real event. Other things can be done with hypothetical events in the future. Now I'm going to answer the question. I understand there was a question during the break that some of your patients get over-sedated 2 hours after. They get sleepy, get nausea or something like this, right?
Ya, jadi tadi ini Bu Kristina tadi nanya kepada saya, gimana kita bisa melakukan BDRC kalau dia habis minum terus?
The thing that I didn't address because I thought it may be obvious, but it may not be obvious. When do you do BDRC and when you don't do BDRC, or when do you do counseling and when you don't do counseling, depending on the state of your patient.
Nah, ini memang
Some places people come up with a smart idea to enhance participation rate by doing BDRC counseling or other form of counseling immediately before medication, essentially putting a contingency. You do not get methadone until you go to the counseling. You need to, in order to make sure that you go to the counseling, you're gonna, this is the sequence. First see a counselor, and then bring a slip of paper from the counselor that then you're gonna get methadone. And I don't do this. I try to do it the other way around, because the patients, at the end of the 24 hours, they may start slowly developing. They all may be worrying about developing withdrawals, or there's a lot of anxiety around this methadone, and I don't like both the contingency part, and I don't like that they may be too anxious and just going through the motion in order to get the methadone. I prefer the other way around. I prefer them to take the methadone first and be done with this, so now they can focus with counseling and working with me.
ya.
Yes, that's a very important point Marek just brought up. Because if you remember those curves of the dose levels, the methadone level goes up and then slowly comes down. and by the time they're ready for the next dose, they're oftentimes in mild withdrawal, and they won't pay attention to what you're saying unless they're medicated.
Ya, jadi kita mungkin ingat ya pada kurva tentang kadar metadon dalam darah ya, dia akan sampai pada puncaknya, kemudian drop, turun, dan kemudian pada hampir 24 jam dia mungkin sudah akan mulai merasakan yang namanya withdrawal, putus zat secara ringan yang membuat dia nggak fokus pada apa yang kita omongin.
So you don't want to do counseling in a state that they are either uncomfortable or intoxicated. So another time when you don't do counseling is the patient just used drugs and he's high. It's clearly under the influence of heroin or other drugs, or drunk or whatever. It's, I don't know whether you can tell, but I can tell. And I can ask the patient if I have a problem, you see that maybe I ask him when was the last time you used drugs. It looks like you may be a little high. And he said, I just had to use an hour ago or something like this. I reschedule, I postpone. I do not do counseling when they are under the influence of drugs. There's no point. It's similar. They will not pay attention.
Yeah.
Oke, jadi ada dua kondisi yang benar-benar yang tidak dianjurkan untuk melakukan counseling adalah
Common though to have a patient who skips counseling, comes in, gets his methadone, and leaves. And we had a grade 8 series of steps to handle these cases. First was we would put a little reminder at the kids to sign in. I'm not sure they have to sign in here. When they come for the methadone, do they have to sign a piece of paper or register each day?
register.
Yeah. So we would put a reminder on it. And if that didn't work, we would do what was called, we would put a soft hold on his medicine, which meant that he wouldn't get his medicine unless he was talking to the counselor. And if he had a good excuse not to see the counselor,
Yeah,
it's a very fixed process. It's a very fixed, like every session goes the same. It's very structured. Both the sessions are structured and the goals of the treatment are structured.
Jadi ini bukan suatu akhir yang terbuka ya. Jadi ini sangat terstruktur, sudah jelas kapan berakhirnya. Jangan buat pasien tergantung sama kita karena dia harus cepat atau lambat mandiri.
So in essence, what you see on the slide is a summary of the DDRC process, something that I'm asking you to do. You want them to achieve abstinence for a short period of time and engage in alternative rewarding activities. This in turn increase their level of confidence and satisfaction from therapy, from life, from progress. They start seeing hope that change is possible.
Ya, jadi proses DDRC antara seperti yang ditulis di sana yaitu mencapai suatu kondisi abstinen untuk periode yang singkat dan adanya keterlibatan ya dalam suatu tindakan-tindakan atau aktivitas-aktivitas yang menyenangkan sebagai pengganti dari kebiasaan pakai dan meningkatkan tingkat kesadaran pasien, tingkat rasa percaya diri pasien dan kepuasan dia atas kondisi terapi yang dijalani.
The intervention that you're going to do is a series of short-term contracts between you and the patient to engage in specific activities to reach immediate goals. So the ideal is there has to be contract at the end of each session. The BDRC is not a talk therapy. You talk, but you talk about things that needs to happen outside. And if things do not happen outside, it's not yet BDRC. Things has to start happening outside. And then it is BDRC. Patient. It is important that you think about the counseling session as an opportunity to teach them new skills. Counseling is an opportunity for them to learn something, but then they have to practice it outside in order for this learned knowledge or the skill to be actually effective and for them to be able to keep this skill for a long period of time and retain it in life, in recovery, rather than just use it once and then forget and abandon. So they are a model of structured activity, of planned and structured activity. This is important, that these sessions are not on demand. They don't happen when the patient needs them. Because if we didn't do this, but one of the typical characteristics of substance abusing individuals, if you ask them a question, what is your plan for tomorrow? What are you planning to do tomorrow? What do they say? I don't know, right? They don't have any structured activities. They go with life as it comes. And this is one of the vulnerability.
Ya, jadi
Important vulnerability.
Jadi-
Treatment or in counseling is one of the first structured plan activity that has explicit rules, explicit expectation. They learn that this can be done. That things do not happen to you. That you can plan ahead and you can go with some longer sequence of events, which is called a plan. And this is a better way than handling things as they come. Then you coach them, you help them to create similar structured activities in the other aspects of life. You ask them, you teach them, you encourage them to make realistic and short-term plans rather than these big plans. Getting married, buying a new house, getting a Ferrari or whatever they want.
Jadi selanjutnya nanti
Why we came up with this therapy is that changing behaviors on your own is not easy. We just tell them change. You have to change. You need to change because we keep telling them it's not going to happen. It's difficult. The change is difficult. And the reason why it's difficult is because it took many years to develop, to get where they are. They tried already many times and they didn't. They were unable, so they give up. They are kind of demoralized. They don't believe that the change is possible. New ways of doing things are much harder than old ways of doing things. They often set very high goals for themselves and they keep failing. So we want to undo all of these. Research and clinical experience, we know that well-defined, achievable goals, small step approach to defined plan, with not just do this, but telling them how to do, what to do step by step. Solving one problem at a time. Active involvement. Not you, it is not your responsibility. You do something for me, help me. No, it is you. You can help yourself. I'm going to help you. Persistence, learning and practicing new skills. All of this combined increases the likelihood of success in behavioral change.
dari
I'm not showing more slides. But this is, again, it was a long 4 days. Right? For you guys. I can do it. I've done it many times. So for me, I have a lot of practice. But for you, it was probably difficult.
Ya, ini memang 4 hari ini cukup panjang ya, 4 hari yang cukup panjang buat Bapak Ibu. Marek sudah terlatih dalam hal ini, ya.
It was difficult. It was tiring for me too. But you were very good audience. You were participating and giving a lot of good feedback.
Ya, sebenarnya Marek juga ngaku bahwa dia juga capek ya. Tapi jangan khawatir, ini bukan sesuatu yang sulit sebenarnya, bisa dipraktikkan. Jadi apa tadi? Ya, pokoknya kita sama-sama capek lah ya.
I learned a lot actually. I learned a lot from you. I know more now about your work, about things going on in Jakarta and etc. So it was. I'm glad I did it. It was very useful, very helpful for me too.
Marek bahagia karena partisipasi Bapak Ibu dan sebagainya, dan Marek belajar banyak dari kita semua.
I even think I got some ideas how I can become a better teacher based on what I experienced.
Sekarang dia sudah punya ide bagaimana akan menjadi seorang guru yang lebih baik nih, berdasarkan dari pengalaman dia 4 hari ini dengan kita.
But the 4 days, no matter how many days we spend, I'm not be able to show you everything that you need to learn. And you don't need me to show you anything. You need to understand the spirit. You need to understand main principles, and I think you do.
Tidak peduli berapa lama kita akan belajar, Marek tidak akan mungkin membeberkan semuanya secara detail. Ya, mau lama mau pendek nggak jadi masalah. Tapi yang paling penting adalah Bapak Ibu mendapatkan spirit, ya, spirit daripada BDRC ini sendiri, dan Marek melihat bahwa Bapak Ibu mendapatkan spirit itu.
And we have a sort of implicit contract. I don't have to work on the contract with you because we already have an implicit contract. Implicit contract is that you know that you're going to be working in the study, and you know you already agreed that you're going to get a patient in a week or 10 days or something like this.
Ya, dan Marek mengatakan bahwa kita sebenarnya sudah terikat juga secara implisit dengan suatu kontrak ya, tidak tertulis tetapi secara implisit, yaitu kesediaan Bapak Ibu sekalian terlibat di dalam suatu program penelitian. Paling tidak, salah satu yang paling jelas adalah kesediaan Bapak Ibu sekalian mendapatkan pasien pertama dalam seminggu atau 10 hari ke depan.
And I gave you contract. I gave you step number 1, step number 2, step number 3. The other day, today I gave you another 1, 2, 3, 4, 5. So you have a contract. You have a one-by-one contract. I even have my notes, so it's written.
Jadi sebenarnya Marek melakukan mediasi kepada kita. Karena kita juga diberitahukan kan sudah apa langkah pertama, apa langkah kedua, dan keempat, kelima, dan seterusnya kan. Marek menuliskan itu semua di dalam kertas kerjanya.
The contract starts like this. Next week or in 10 days, you're going to see your first patient, and you're going to do 1, 2, 3, 4, 5, 6 with the patient.
Jadi bunyi
Next
kontrak,
week or in 10 days. Or
bunyi kontraknya adalah dalam waktu seminggu ke depan atau 10 hari ke depan Bapak Ibu akan mendapatkan pasien, melakukan mediasi dan melakukan langkah-langkah 1, 2, 3 dan seterusnya.
And next time when I come to Jakarta, it will be maybe in a month or 2 months. I'm going to ask you. So how did it go? And you're going to tell me back how did it go? And I'm pretty sure it will go fine.
Second session of the mediation counseling for us.
Right.
Ya, jadi sesi counseling yang berikutnya dari Marek kepada kita nanti dalam waktu 1 atau 2 bulan ke depan adalah Marek akan bertanya, bagaimana Anda melakukan itu? Apakah Anda lakukan atau tidak?
Or maybe it will happen next month over the conference call via Skype or telephone, where I will ask you, remember when I was there, we had this contract, we're going to take the patient, tell me how it will go. So yes, I'm serious, this is what will happen.
Ini Marek serius loh Bapak Ibu sekalian, sebagai terapis ya, sebagai konselor buat kita ya. Nanti dalam 1 atau 2 bulan depan Marek paling tidak secara teleconference. Jadi teleconference itu bisa dari jarak jauh dia akan tanya kepada kita. Ini terakhir kita kemarin sudah sepakat untuk melakukan 1, 2, 3. Bapak Ibu lakukan nggak?
Yeah, so do we have a deal?
Jadi kita sepakat ya.
Yes, okay, so we're gonna close the deal with a shake hand.
Kita tutup kesepakatan kita dengan
Thank you.
salaman. Marek, what if they don't have new clients within 10 days?
Thank you. Thank you. Well,
What if they don't have new
they
clients?
will, don't worry about it. That's Ali's problem, not mine. It's you and I. If they don't have a client, they talk to you. I did mine.
Jangan khawatir, Bapak Ibu pasti dapat masalah. Karena ini adalah urusannya Dokter Adi, bukan urusannya Marek, bukan urusan saya.
Bahasanya ya 1 bulan baru dapat udah lupa.
Nggak bisa. Oh, they just receive the new clients within 1 month.
I can tell you, I don't do what if questions.
Marek nggak
It's
suka
your problem.
seumpama-seumpama.
I only deal with real problems.
Kita pastinya sudah
Urusannya Adi, bukan urusan Marek.
No, I already gave you another message, and you asked me this. You can, if you like any of this that you learn, if you want to use it in your private practice or in other setting outside of the study, you're free to do that. Right? It's yours. You own it. You can do whatever you want.
Bapak Ibu dipersilakan menggunakan teknik ini dimanapun, ya. Di luar masalah studi, nanti kan ada ikatan-ikatan untuk penelitian tuh ada sendiri. Di luar itu, Bapak Ibu mau menerapkan ini di tempat praktek dan silakan. Bapak Ibu sudah dapat keterampilannya.
You don't have to wait until next week. You can try it tonight. If you see a patient tonight and there's something that you want to do that from what you learned, go ahead, do it.
Kalau Bapak Ibu nanti malam ada pasien terus mau melakukan teknik ini, silakan lakukan. Jangan nunggu sampai seminggu, udah 10 hari lagi.
Could you please teach us how how to deal with patients who want to quit methadone. I mean, they really want to stop using methadone because they want to have a life which is free of drugs, including methadone. How should we react or say
You saw. Do you want to translate this first, or you want me to translate?
Bisa nggak ngasih tahu caranya bagaimana kalau kita harus menghadapi pasien yang pengen berhenti dari metadon?
If you remember what George did, she said, I want to reduce, and he asked, why do you want work? So this is essential, and she said, because it may damage my liver or something like this. You need to educate them, you need to find out why, and basically we do not recommend, and they, for the study, for the duration of the study, they must remain on methadone. Well, yeah, must is not the word. They will. We won't be reducing, we won't be detoxifying them. It's not recommended. There are many ways of dealing with this. You need to find out why they want to do it. You need to assure them it's not toxic, it's not going to damage the liver, it's not. You need to find out what they know.
they are also addicted to methadone? If they are dependent to methadone?
There's a number, no, but methadone is not addictive. It is addictive substance, but it's medication. So I always use the following example. That let's see the benefits. Let's see whether it's working. Okay? And if it's working, why would you change the medication that works? Nobody does it. There's no, you wouldn't make a recommendation to a patient who is functioning normally while taking insulin or taking blood pressure regulating medication by removing it. Yeah, well, let's see whether we can manage it without medication. So, this is a little more complicated story, but and I cannot give you a quick answer, but these are kind of the lines of answer. Yeah.
It's a common issue. The patients ask us many times. And what I always say is, first we want to evaluate how they're doing. And some patients will insist, and you can't say no.
Ya, jadi tadi jawabannya Marek adalah untuk kepentingan penelitian kita hendaknya mendorong seseorang untuk tidak keluar dari metadonnya sedapat mungkin tidak mendorong keluar. Kalaupun dia tetap bertahan, pengen banget keluar, kita sebaiknya mencari tahu. Kemarin contohnya di sini Mela ya, dia kenapa dia mau berhenti kan karena merusak liver dan sebagainya. Kita mengedukasi mereka sesungguhnya. Mengedukasi dulu, barangkali ada sesuatu mana yang salah ya. Nah tapi ini George menambahkan lagi bahwa bisa saja pasien itu ngotot pengen keluar.
And some patients will succeed, but not a lot.
Ya jadi pada sebagian orang itu memang berhenti dari metadon tuh ada yang bisa berhasil. Tapi nggak banyak.
Patients that are most likely to succeed are those who have not been using any drugs for 3 or 4 months, who are psychiatrically and socially stable, and ideally have a job and aren't associated with drug-using friends. And even with that selected group, the relapse rate could be as high as 75%.
Ya, jadi dari pengalaman Budi, dari berbagai penelitian, hanya orang-orang dengan latar belakang tertentu. Contohnya adalah orang dengan stabilitas kondisi psikiatrik, emosional yang stabil, yang punya pekerjaan yang biasanya sukses. Tapi itu pun di kalangan populasi yang spesifik seperti ini saja, relapse rate-nya atau angka relapse-nya itu bisa sampai 75%.
So if the patient, insists, I would, and I've done this many times, just slowly bring down the dose in collaboration with the doctor, and just make sure the patient knows the risks, understands the risks, and you get the patient's agreement to go back if he starts using drugs. And you also get the patient's agreement that if he does successfully detoxify, that he comes back immediately if he starts using drugs. Because his risk for overdose is magnified after he comes up because he's lost tolerance. When he's on methadone, he doesn't have tolerance. So there are a lot of risks, but you can't say no if they absolutely exist with as well.
Ya, jadi kalau pasiennya masih ngotot juga setelah diedukasi dan sebagainya, kita buat semacam perjanjian dengan dia, kita bisa mulai untuk menurunkan dosisnya. Tetapi kalau kemudian kondisinya menjadi kurang stabil lagi, sudah ada perjanjian di awal bahwa dia bersedia untuk dinaikkan kembali. Kalaupun dia nanti sudah stabil, kemudian dia selesai dari detoksifikasi, kemudian dia tidak stabil lagi, dia juga berjanji untuk segera masuk ke dalam program kembali. Karena sekali lagi kita diingatkan bahwa kemungkinan orang untuk overdosis setelah dia sudah tidak lagi toleran adalah jauh lebih besar.
Yeah, and if they request and insist and they are unstable, they haven't stopped using drugs, so they try very hard to make them change their minds. You know, one thing that oftentimes works is you say, well, here you are, you can't stop using drugs when you're on methadone. How do you expect to stop using drugs if you're not on methadone? You know, and a lot of times the logic of that.
Buat pasien-pasien kita yang kalau beberapa kali swab check masih positif, tapi ngotot mau berhenti, kita bisa ngomong sama dia. Nah, bagaimana kamu bisa berhenti pakai di luar? Kalau dalam kondisi pakai metadon saja, kamu masih terus pakai, gitu loh. Jadi kita tidak mendukung lah kalau dia ingin berhenti.
And one more thing is to reassure them that methadone, when taken as prescribed, does not have toxic effects. It doesn't hurt your liver, it doesn't hurt your heart, it doesn't hurt your, make you demented. Alcohol is much more toxic, or high doses of benzodiazepine.
Or street heroin.
Or street heroin, for sure. You do have a physiological dependence, which is an issue if they want to come off and do. But they can safely take it as long as they're using just for years without any evidence of serious harm. And that is reassuring. Sometimes they're afraid that it's going to hurt them, but they don't really know. It's just irrational people. So that kind of education.
Ya, jangan lupa untuk meyakinkan dan mengedukasi lagi kepada pasien bahwa metadon itu tidak memiliki efek toksik yang dikhawatirkan sepanjang digunakan sesuai resep. Ya. Alkohol yang digunakan di luar, kemudian juga putau yang diperoleh di jalanan itu jauh lebih toksik daripada metadon bila mana itu digunakan sesuai resep. Jadi edukasi lagi, diyakinkan mereka, karena mereka kan mendengarkan itu ya, rumor-rumor dari luar ya.
So I just want to put it in the right context. In the context of this study protocol, when we are enrolling, in principle, we've been enrolling new patients for a 1-year treatment. There shouldn't be there's no place, there's no plans, there should not be any plans for reduction or getting them off during this type of treatment. This should be clear. And I want to emphasize that all of this what George said, but we do not plan this, and it's way too early for anybody to succeed. Now, can you translate it?
Ya, jadi untuk protokol penelitian kita, tolong dapat ditekankan bahwa kita tidak sedapat mungkin tidak membuat ada yang namanya menurunkan dosis. Jadi apa yang tadi di Josh katakan tadi adalah kondisi secara umum. Tetapi untuk penelitian, untuk protokol penelitian itu tidak dibenarkan untuk dia turun dosis atau keluar dari program.
In a general clinical practice setting, when you have a patient, independent of study protocol, and who has been making progress on methadone, this situation is slightly different. It could be slightly different.
Jadi kalau ada hasil penelitian yang Bapak Ibu pernah baca yang mengatakan bahwa dia cukup stabil di luar dari penggunaan metadon, itu merupakan suatu hal yang mungkin berbeda ya.
But if you are successful in educating the patient about how treatment works and the role of methadone and the role of other things, you're also successful in convincing the patient that methadone is important but not the only thing that works, and it's not necessarily the most significant. It's very important, especially in the initial stages of recovery. but it's also very easy. It's easy to take methadone. It's easy to stay on methadone. It's actually medically, it's actually relatively easy to taper down the person very slowly to the levels that they kind of comfortably feel no effects of withdrawals with very low or no doses of methadone.
Jadi kalau kita berhasil mengedukasi mereka, mereka akan tahu bahwa sebenarnya ini sesuatu hal yang relatif aman ya, tidak ada lupa.
The difficult part is the behavioral part, the part of repairing your life, the part where you make changes, where you start living a happy, normal, successful life. So I would say, if I see a patient who has a sustained abstinence, having used any drugs for a long period of time, is working, has a family, has things to do, happy, no psychiatric comorbidities, no medical comorbidities, essentially living a life like any one of us, and the only thing that's bothering him is methadone, I would actually try with a patient like that to, if he insists on getting rid of this, if methadone is the last thing we're standing, then in a situation, hypothetical situation like this, it is possible. And it happened to me several times. Patients can stop using methadone, unlike patients, for example, who suffer from diabetes. Very few of them will ever stop insulin injection.
Ya, jadi kalau kita berhasil mengedukasi dia dan kemudian meyakinkan dia bahwa yang namanya methadone cukup aman, biasanya dia akan bertahan. Tapi kita juga akan berhasil meyakinkan mereka bahwa methadone ini hanya setengah dari perjalanan pemulihannya. Kalau perlu ada hal-hal yang lain yang bisa dilakukan oleh mereka untuk bisa melengkapi proses pemulihannya, pekerjaannya, keluarganya, dan sebagainya. Itu yang perlu ditekankan dalam proses edukasi tentang masalah methadone.
Methadone maintenance or taking methadone, prescribing methadone should not be your concern, because this is not, I assume, it's not your domain of expertise. You are counselors, or if not, you are playing counselors' role in the study. You are not the prescribing physicians. So the most easy way of dealing with these concerns is that the patient needs to discuss with the physician the tapering or not, and etc. This is a kind of easy avoiding situation. I myself, I'm a psychologist in the United States. Even if I am a professor, I still cannot give a person a methadone. You are MD, George. Okay. So I will have George to prescribe methadone to my patients, and I never prescribe methadone to my patients.
Ya, jadi Bapak
I think let's finish, because you guys, I think we are late for lunch, and we're kind of touching on. Yeah, let's finish.
Bapak Ibu, ya kita akan segera menyudahi. Diharapkan adalah pada Bapak Ibu adalah tidak meresepkan methadone. Diusahakan, karena peran Bapak Ibu dalam penelitian ini, untuk khusus yang penelitian ya, adalah sebagai konselor. Jadi urusan naik turun dosis dan sebagainya silakan diarahkan kepada teman kita yang lain.
Buat peneliti aja, pasien yang peneliti aja, misalnya itu
Kalau yang double ya, tugasnya double juga resepnya nanti tanya David sama Adi. Iya, nanti itu bukan, kita nanti harus bedakan mana pasien yang tidak masuk di dalam program, mana yang masuk. Untuk masuk di dalam program kita harus jelas.
These are procedural issues. They have nothing to do with what I do.
Ya, jadi nanti ini akan dibahas ya.
After lunch, we're going to come together, the whole group, in one room, and there will be brief summary and answer question and answer.
Ya, silakan ditahan Bapak Ibu pertanyaannya, nanti pada saat habis makan siang kita bisa tanya, bisa. Silakan makan siang.